Hello, namaste, and welcome to Delhi. I'm Devina Gupta, and this is Work Life India on the BBC, the show that looks at all things to do with money, the work we do, and the lives we lead. Now, India is facing a health crisis. More than 100 children have died due to an outbreak of encephalitis in the eastern state of Bihar. Encephalitis is an inflammation of the brain mostly caused by a virus. The poor are the worst affected, and the inadequately staffed and ill-equipped public health centers are struggling to cope. This raises a very urgent question. Can India afford healthcare for all? The Indian healthcare system is riddled with ironies. On the one hand, there is a booming private healthcare business with swanky hospitals and trained staff. And on the other hand, there is a vast network of government-run or publicly funded hospitals, but they are bursting at the seams and often lacking in basic resources. So is there a solution in sight? To talk all about it, we have with us Shobana, who's Executive Vice-chairperson of Apollo Hospitals, one of India's private leading hospital chain. Hello, Shobana.
Good evening. I'm definitely an owner, but not of swanky hospitals, but of extremely competent hospitals. And I think that's what the private sector in India
We talk
does.
all about it, Shobana. Let me introduce the other guest that we have, Dr. Reddy, who is part of the Public Health Foundation in India. He's been training public health workers here and also focusing on health policy. Dr. Reddy, welcome.
Thank you, Devina, for putting the spotlight on the health system.
And we also have Dr. Yogesh Jain, who's traveled from the interiors of the country, from central Indian state of Chhattisgarh, to be here with us and talk about the challenges in the rural and the tribal belt of India. He's been practicing medicine for 20 years there. Welcome, Dr. Jain.
Thanks for inviting me also.
Well, let me start with you, Dr. Reddy, on that note, because as Shobana just said, that it's the private health sector is often referred to as the swanky hospitals, because that's where we see 70% of Indians going for health checkups, because there is a trust that they'll get good service. But what's happening in the eastern state of Bihar? Why do we have so many deaths there? And why is it that private health sector is not able to cater to these?
It's a combination of circumstances. Firstly, you have poor social conditions, where there is a huge amount of malnutrition. In the state of Bihar, about 48% of the children under 5 are malnourished, stunted. And in that setting, they're much more prone to infections. Or even if it's a toxin, that's much more likely to affect them because their immunity is very badly depressed. And when they do fall ill, the health system is unable to provide care close to home. Why is it that these children have to be taken hundreds of miles away to a large city hospital when this firstly could have been prevented, and secondly, care could and should have been given at the sub-centers and the primary health centers, or at the maximum in serious cases in the district hospital. So the fault lines run across the entire health system, and we have seen these little children paying the price for it.
What's the condition of these city hospitals and the public hospitals in the interiors of the country, Dr. Yogesh?
Yeah, I would say that what this crisis shows is that everything that people in rural India require is actually broken in terms of health systems. So we have poor human resource deployment. Physicians who are there predominantly in the cities and not moving out into the rural areas, and those who are there also are not accounted for, and we have not invested in other cadres of human resources as much as we should have. Secondly, we haven't we have not developed systems, even though we have increased access to some systems, developed some infrastructure over these years. But we have not, made them functional. So, the institutional delivery model that the country has had, institution is not only four walls. You have to have systems within it.
Absolutely.
And which have not happened, and then the poor funding has led to poor availability of drugs and diagnostics. as well as training quality of the human resources, that accountability, use of other technologies that are available elsewhere in the world.
And why is it not happening is the question, because when you talk about spending, well, private sector in India is actually booming. There's a $61 billion healthcare market, Shobana. And when you said that we're referred to as swanky hospitals, but there is the truth to it that only people who with money can afford that healthcare. But these people who are in the eastern state of Bihar are actually the poorest of the poor, who can't really afford a private medical treatment and paying the price. Why should quality healthcare be only for the few?
Devina, this is what happens. Everyone, it's easy to go after the private sector and say that you guys are swanky, you guys fleece people, but really that's not reality. Reality is the fact that all our hospitals, they're not 5-star. We have general ward beds, we have free beds, lots of free beds. In fact, 800 of our beds do the Ayushman Bharat scheme, which is India's access to the poorest of poor, 500 million Indians on the government health insurance. So we're all participating in that. But what we do distinguish ourselves is outcomes. And when you need to put up these expensive facilities, you buy land at commercial rates, you borrow at commercial rates, and you start paying for the best of doctors and staff and get JCI, the best of the best accreditation. At that point, it all adds up and it costs money. And when you're doing this, so I think that if you look at it as a business model, you're probably, we could have been doing other things, but we're passionate about what we do. And what most people in India, the hospitals that have come up for a social reason. And the fact that we have to pitch in and do 70% of India's health, I think that speaks for a lot. That
But that's also because, yes, Yogesh, you have a point to make. Go ahead.
So I would add to what Shobana has been saying. In an unequal country, in an unequal society that India is, in a large measure, it has to be the public system who has to provide predominant care in the country, and private sector can be sourced in for care where public system requires care, requires support. And I think that is the thing that we should be asking. But I would also, counter what she has said about 70% that of the expense of the care is provided by the private sector at the moment. It is not that people have chosen to go for that. It is when there was a dysfunctional or an absent
That's what I
health
was
system.
coming to, because there is no choice which is given. Imagine you have a loved one who's going through a serious health crisis, and you just want to get the best of healthcare. In fact, even people from rural India, and this is a study that was done recently, 60% of them actually go for private healthcare. They have to sell their land, they have to borrow a huge amount of money to do so, just so that they can get access to quality healthcare, which they know is not available in public hospitals, but in private hospital like yours. So shouldn't there be certain parity in terms of cost? I actually went to your hospital website and checked this out. If you want to get a sugar test done, it costs less than $1 in about 50 cents in a public hospital. In your hospital, it's about $200. How do you justify that?
It's not $200 because that's outrageous. You got your the H1B test would probably cost, I think, somewhere around 500 rupees. It's less than $10. So if you look at it to international standards, and people are not costing for the not just the technology, but the doctors, the lab technicians, everything behind it. So you just say this is the cost of the consumables, doesn't give you the actual cost of what it is. And when you look at this hospital and why you come, I think you should look at it more holistically and measure it up. You'll see that all of us have a lot of parity in our costs, and on top of that, we're less than 1/10 of what it costs anywhere in the world. So there's nothing like $200. For $200, you could probably get your medicines for a year.
Well,
That's
I
India.
hope that was the case.
That is India.
But when you say that the healthcare cost, even if it's according to you, say about $500, 500 rupees, which is roughly, say, about $3 to $4 in India.
This is not the stick test.
But let me come to you.
That is 10
in a
rupees.
country
That's
where
10 rupees.
in a country where you have most of the population, which is around over 60% of population living in villages, earning less than $1, how do you justify it to these people?
Devina, actually,
Yes.
This test is very
7%.
Dr. Reddy, go ahead.
7% of the Indian population are pushed into poverty each year because of unaffordable healthcare costs. It is also now recognized to be a major cause of rural indebtedness and farmers' suicides. About 63% of the healthcare expenditure is out of pocket. So clearly, many of the Indians are unable to afford the healthcare expenditure. So we need to find solutions for that. And we can't depend upon a very expensive model. And much of the brunt has to be borne by a competent and compassionate public sector.
Well, on that note, let me ask you, if you're saying that the government spending needs to be higher than for public sector, but right now we see that the Indian government is allocating somewhere just higher than 1% of its GDP. We are behind China when it comes to public spending in healthcare. We are behind developed countries like the US and the UK when it comes to spending on healthcare. So how do we construct more hospitals? How do we incentivize doctors like Dr. Yogesh to actually move to rural areas and serve the people there?
See, even in the United States, which is seen as a poster child of private healthcare, 48% of the expenditure on healthcare comes from the public sector. So we do need to spend a lot more than what we are doing now, though we can't immediately compare ourselves with China, which has a much larger economy. But we do need to spend certainly more than 1%, closer to 3% at least. And we also need to spend it better. We cannot spend it mostly on tertiary care. We need to spend it a lot on primary health care and district hospitals and strengthen them so that actually most of the needs of the largest segment of the population are well met in an affordable manner.
And Dr. Yogesh, if there is a scenario that we actually start spending more on public health care, there are public hospitals in rural India, are doctors also willing to give up the city job, high-paying job from private hospitals as well, and go into the rural areas and serve there?
I wish they did. But my own feeling is that doctors are not going to go to rural India in large proportions unless we have a overall change in the society's well-being and also the infrastructural development that we require more this inequity between the rural and urban areas changes. At the same, but this also tells us that if doctors are not going to be the going to go in larger proportions than now, larger numbers than now, we need to develop human resource capability among mid-level health workers who should be competent.
What motivated you to take that decision?
Well, my own motivation was to repay the social debt that one has incurred by getting training in public institutions, and my concern for equity, which was also the shared concern with colleagues and friends who moved in together. But that may not, that change may not happen. I can't expect that from the predominant physicians in the country, because they are, largely a reflection of the middle class aspirations of the
And it's a difficult choice. Shobana, you talked about being part of this healthcare scheme rolled by the government called Modi Care. Now it's about $7,500 given to almost the target is 500 million people to be covered there, and the hospitals have been given subsidy for the treatment that they offer. But has it unlocked the door of quality healthcare for those who are in the poorest of the poor chain, or has it led to more burden of finding resources in private setup as well?
It's early days yet. The scheme is not even a year old. And I think that there'll be, there's lots of course correction going. There's no subsidy as such, but what it gives is, and our health insurance company actually does a state, and you get, for a family of 4, you're actually paying something like around 300 rupees. 300 rupees is what, 3 pounds. You pay 3 pounds and it gives you access to $7,000 worth of healthcare for the year. That's like an open heart surgery, cancer treatment, Of course, it's limited because it's only for inpatient. So I think that that's one of the things of the scheme. But what it does is that it is going to encourage and create demand in rural areas for which private healthcare and of course the government needs to step up. But in one of the rural areas, we've taken the government hospital and converted it. So there'll be fresh models coming up. There'll be technology models that with telemedicine coming up, because you have to understand, this is the thing that India spends $120 is the healthcare per capita spend. So in that 120, whereas in England, for instance, it's about £4,000. US, it's $10,000. So this is where it is. This is the way that hospitals, like you say, we're continuously vilified that we charge with this. But just remember, it's $120 per cap, and we're all giving you the best of quality care within that. India does the most number of open heart surgeries, most number of transplants.
And isn't there a divide then, Dr. Yogesh? Because on one hand, you have private hospitals saying we give the best of services. On the other hand, you have rural India in which there is still much more to be done. I want to bring in, what are the solutions then? What are the solutions that we can look at? Because as Shobana mentioned, one of them is telemedicine. Now, do you see that working in India, where you have a doctor who is sitting in one part of the country and is connecting to patients in remote areas over cell phone or over mobile phones? Does that work?
So I would say here, we when we get to technology use in healthcare, certainly we do need technologies, of which information technology is one, and its various forms that one can use. But I think what we require far more is human technology. We require human resources who are trained, who are serving, who are accountable, and who also could use information technology, but not as the game changer, but as a supporting thing. And we also use a lot of information technology in rural areas. The Apollo Hospital group is also supporting it in many ways to so many hospitals in the country, so many other health providers. But that alone, or that cannot be the predominant, game, the changer.
Well, the other initiative,
but I would say
yes,
here,
go ahead.
In terms of what the country requires, is universal health care, which includes healthcare coverage plus acting on the determinants of health.
Absolutely.
If you're talking about the context of these deaths that have happened here, and prevention, I mean,
absolutely.
So they, acting on determinants. If nutrition was worked upon, for example, we have known it for a few years that these deaths that have happened in Bihar have been happening every year, but we have chosen not to work on nutrition as a major determinant.
And that's the area that you actually actively work in, Dr. Reddy. And why is it that still the preventive health care is not the first step which is being taken by many states? Some states are doing it, like Tamil Nadu has had in southern India, stellar record of preventive health care. How have they managed it while the other states haven't?
See, prevention acts at multiple levels. Firstly, you require policies which actually change the social conditions, whether it's nutrition, water, sanitation, or making unhealthy foods costly and healthy foods cheaper, or control of tobacco, all of that. But then you also require a lot of community empowerment through health literacy and enabling them to protect their own health. And of course, number of preventive services like immunization and so on and so forth. All of these have not been given adequate attention because we have neglected our health system. And therefore, we are all the time doing the mopping exercise of treating very sick patients who come to the hospitals. So we need to actually invest more resources, financial and human, in terms of prevention and health promotion.
What are the models that you would suggest?
Well,
international models that have worked for other countries, which can be adopted by India?
Well, in our own neighborhood, we see Sri Lanka has done it very well. Even Bangladesh and Nepal have started doing it quite well in terms of good primary health care, community empowerment, women's empowerment in particular. Thailand has an excellent system of primary care as well as universal health coverage, and even advanced care is provided with low degree of financial burden to the people. But one of the things that we must recognize is we should not talk only of a doctor-dependent primary care system. Much of the functions of primary care, whether in rural areas or urban areas, can be performed by mid-level health workers, nurse practitioners, trained community health workers. And my own colleagues have shown in Himachal Pradesh that this can be done very effectively.
Absolutely, absolutely. Shobana, where can private hospitals come in, and where could there be a public-private partnership that can be explored so that the technology that we're talking about sitting here in the capital of India can be taken into interiors where Dr. Yogesh is working?
So I'll give you an example actually of nutrition and what it changed. During Indira Gandhi's time, remember when there was a huge iodine deficiency, entire population, and they made it compulsory for salt.
This is late 70s, early 80s that we're talking about.
Yeah, late 70s. For India to have iodized salt became compulsory, and we just wiped that out. If you look at the milk revolution, and I think these are the changes that it's not just hospitals, but the entire private sector. So, fortify some of the biscuits for children with this. This is something that a friend of mine, Vinita Bali, has been speaking about. So it's not just hospitals, but hospitals can play a role in terms of bringing these kind of solutions. So we go into the villages and we do huge health camps, but there we use technology. On an Apple device, you can actually do cervical cancer screening so much better. So the point of care that you have, the new things that are coming out of point of care that can get we need to identify disease faster.
And Dr. Yogesh, is that working?
So I would like to again say, I've once said it before, that it is unfair to expect the private health systems to be the predominant care provider
States like Delhi, let me bring this in, because states like Delhi, for example, have started this neighborhood clinic where there is primary health care given, free diagnostic, free medicines, and they have done at least 100,000 clinics around Delhi, providing this kind of service to 2 million residents approximately here. Can this model be replicated in other states?
So I would say, to carry on with where I left earlier, we have to have the public systems delivering the bulk of the care in this country. And in this case, I would like to criticize the model that we have at the moment, which is the PMJY at the moment, because it is at the moment...
Which is the Modi care, dubbed as Modi care as well.
That's variably said as that, but where, yes, we are providing curative care in form of inpatient care for some people who are officially called poor, but not for all. And I feel instead of that, and there is also a community level intervention at the sub centers, which are now going to be called health and wellness centers. But that care is not still can't be called even universal health coverage. We have to care for everyone. There cannot be two types of care.
So affordability, absolutely. What you're saying is there is affordability when you talk in terms of universal health coverage for inpatient care, but out-of-pocket expenses, which is including medicines, is quite expensive still. I have very little time here. So Dr. Reddy, I just want to have your experience here that India has now experimented with generics. India has experimented with the capping of price when it comes to medical stents. Does that help in making healthcare affordable for all?
Yes, because in 2015, out of the 55 million people who were pushed into poverty because of unaffordable healthcare expenditure, 38 million were because of cost of medicines. So if you can actually make medicines cheaper, or even provide basic medicines and diagnostics free of cost in public facilities, that will have an immediate and early impact on reducing the financial burden. And that's part of universal health coverage.
But Srinath, on this point, I think there are two Indias. We have to provide healthcare for all, but it doesn't mean a one-size-fits-all. And the private healthcare, so if patients don't get access to the latest stents, because they'll stop coming, so they'll go abroad, or if you don't the original molecules. So I think that there
are two Indias, and I absolutely agree with that. With that, I have to wrap up. Thank you so much for being with us. Thank you for tuning in. Do tweet your comment with #WorkLifeIndia.